Thank you, sir, and good morning, everybody. Myself, Dr. Surendra Singh. So, as sir told, we will be presenting our CGR on acute and chronic liver failure. So, first, we will be discussing some clinical scenarios, and then we will be discussing about the concept of ACLF. Then, proceeding, we will be discussing the definitions and various prognostic scores that are used in ACLF, and finally we will be coming to the management and then our experience of managing patients in ACLF. So let's start with the case scenario. A patient which was managed in our department. He was a 43-year-old male who presented to us with history of jaundice for 6 weeks and followed by ascites 4 weeks later, with no history suggestive of hepatic encephalopathy or variceal bleeding. And he was a alcohol consumer for past 15 years, with consuming whiskey in the amount of 130 to 150 gram of absolute alcohol, and his last alcohol intake was 1 week prior to the onset of jaundice. On examination, the patient was icteric. He was also having bilateral pitting pedal edema with moderate ascites and moderate firm splenomegaly. So on investigation, the patient had a raised bilirubin to the tune of 22.5 milligram per deciliter. His AST and ALTs were also raised. AST was almost 4 to 5 times elevated and ALT was 2.5 times the upper limit. His albumin was in the lower range into a value of 1.9 and he had coagulopathy with INR of 2.1. He was subjected to ascitic fluid analysis, which did not reveal any evidence of spontaneous bacterial peritonitis, and his SAG, which stands for serum ascites albumin gradient, was 1.4. So SAG is an important entity. It is used to differentiate patients with ascites, whether they have ascites because of portal hypertension or some other cause. If ascites is more than equal to, if SAG value is more than equal to 1.1, it suggests that ascites is due to portal hypertension. However, if the value is less than 1.1, then we have to look for other causes of ascites. So in this case, the cause of ascites is portal hypertension. The patient was also screened for evidence of any sepsis, with urine culture, blood cultures being negative, and procalcitonin and GIMI within the normal limits. So he was also screened for viral markers, typical as well as atypical, which came out to be negative. His autoimmune hepatic markers were also negative, and so was his IgA TTG, as well as his serum ceruloplasmin value was also normal. So when we did USG abdomen for him, the USG showed evidence of cirrhosis with portal hypertension. Liver was of heterogeneous echotexture with a regular outline with a dilated portal vein, as well as splenomegaly and moderate ascites. And further, when we subjected him for upper GI endoscopy, he had small low risk varices with evidence of portal hypertensive gastropathy. So then coming to some scores which we use to prognosticate patients with cirrhosis or acute and chronic liver failures. First of all, MELD. So MELD stands for Model for End-Stage Liver Disease. It has 3 components: bilirubin, creatinine, and INR. Then its improved version is MELD sodium, which incorporates the sodium levels and is a better prognostic marker. Third one is the Madrid discriminant function, which is used to make a diagnosis of severe alcoholic hepatitis with value more than 32 signifying severe alcoholic hepatitis. And then is the ARC score, which is used to grade the ACLF into grade 1, 2, and 3. It has 5 important components, which I will be telling later. So in our patient, the MELD score was 27 with Madrid discriminant function of 86 and R score of 8. So the final diagnosis of this patient was acute and chronic liver failure, with acute component being severe alcoholic hepatitis, chronic being alcoholic cirrhosis with portal hypertension and moderate ascites with small esophageal varices, with child score C with MELD of 28 and MDF of 95. So after this brief history, let's try to understand what is acute and chronic liver failure. So here in this slide, we are showing 2 livers. This first liver, it appears to be perfectly normal, whereas the second liver, it appears to be altered in its morphology. So the first liver belongs to a normal person. So if such person has any acute insult, which could be either in the form of any infection or any alcohol intake or any drug which is hepatotoxic, then it may lead to hepatic dysfunction in the form of jaundice and coagulopathy. And this patient may progress to acute liver failure. If such patient then develops encephalopathy, then we will call this person to develop acute liver failure. Whereas a person who has a diseased liver at baseline, it may be either chronic liver disease or a compensated cirrhosis, and then he develops an acute insult, and which manifests as jaundice and coagulopathy. And within 28 days, if it progresses to ascites or encephalopathy, then we will say that patient has developed acute or chronic liver failure. So now coming to the definitions of ACLF. So broadly, there are 4 major definitions of ACLF, which are the APASL definition, which is the Asia Pacific Association for Study of Liver definition, the EASL canonic definition, that is the European definition. Third one is the World Gastroenterology Organization definition, and fourth one is the North American definition, which is by the NEXEL group, which stands for North American Consortium for End-Stage Liver Disease. However, we will be concentrating on the 2 main definitions of by APASL and canonic, because these are the most widely used in India as well as abroad. So coming to the APASL definition, so APASL has defined ACLF as acute hepatic insult manifesting as jaundice with bilirubin more than equal to 5 milligram per deciliter and coagulopathy with INR more than equal to 1.5 or PTI of less than 40%, which is complicated within 4 weeks by clinical ascites and or encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease or cirrhosis, and that is associated with a high 28-day mortality. So coming to the R score, which was mentioned before, R score stands for the APASL ACLF Research Consortium score, which was developed to prognosticate patients with acute and chronic liver failure by APASL definition. It has 5 components in the form of bilirubin, He, PT, INR, lactate, and creatinine. And it ranges between 5 to 15. And based on this score, the patient is categorized into grade 1, 2, and 3 of ACLF. Now, coming to the second important definition of acute and chronic liver failure, which is the EASL canonic definition. So it is defined as acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality due to multi-system organ failure. So in the EASL canonic definition, we assess the level of dysfunction or the ACLF based on the organ failures. And they have divided organ failures into 6 organ failures: liver, kidney, brain, coagulation, circulation, and respiration. And the parameters which are in yellow, these are the parameters of which, if the value is present, we define that patient has liver failure. If bilirubin is more than 12, for renal failure, we take cutoff of 2 of creatinine. And for brain failure, we take patient to be in He grade 3 or 4. Similarly, for coagulopathy, cutoff of 2.5 INR. And for circulation, any patient requiring vasopressor support. And similarly, for respiratory failure, PaO2, FiO2 ratio of less than 200. And as the organ failure, number of organ failure increases, the grade of ACLF also increases, and so does the mortality. So now, coming to the comparison of these 2 definitions. So basically, the major difference between the APASL and EASL canonic definition is that APASL has clearly defined that the duration between the acute insult and liver failure should be 4 weeks. However, EASL does not give a time frame of acute insult and then worsening of hepatic failure. Then second major difference is the underlying CLD. In patient with APASL, they have also taken patient with non-cirrhotic CLD to be a cause of chronic liver disease. However, in EASL definition, only patient with either compensated or decompensated cirrhosis are taken. Then another major difference between these 2 definitions is the acute injury. In APASL definition, the acute insult has to be exclusively hepatic insult. Whereas in EASL definition, hepatic as well as extrahepatic insult can be counted as acute insult. For example, if a patient has systemic sepsis, it can be taken up as acute insult in EASL definition, whereas in the APASL will not consider as acute insult. Then coming to definition of APASL ACLF, the liver failure is the central part. For example, if the patient doesn't have liver failure but has other organ failures, then he can be classified as ACLF by EASL definition, but he will not be classified ACLF if liver failure is not present by a PASL definition. Then they have their different scores for prognostication, ARC score for APASL and CLIF-C ACLF score for EASL canonic definition. Now, as we know that any patient with acute and chronic liver failure will have an acute precipitant. So these can be broadly classified into infectious hepatic and extrahepatic insults or non-infectious insults. So broadly, the infectious insult could be either acute viral hepatitis or different etiologies, reactivation of chronic hepatitis B, or other infections which affect the liver. Whereas the non-infectious acute insult could be either the form of alcohol abuse, any hepatotoxic drugs, autoimmune hepatitis flare, Wilson disease flare, any surgical intervention, or upper GI bleed. Similarly, the chronic liver disease component could be either compensated or decompensated cirrhosis of various etiologies, or chronic hepatitis, which could be of different etiologies, ethanol, non-alcoholic steatohepatitis, chronic hepatitis B, C, or AIH. So moving forward now, I would like to invite my colleague, Dr. Ajay Mishra, to take the CGR forward.
Morning to all. Well, being familiar with the ACLF now and the clinical scenarios of ACLF, I would like to take you to 2 more cases of ACLF, and I will discuss the management further. The second case of ACLF, she is 36-year-old female. She had a chief complaints of jaundice for 4 weeks and ascites for 1 week. So here we can again see the difference from the jaundice onset to ascites onset was less than 28 days. And the jaundice was progressive, painless, non-cholestatic, and the ascites was also progressive, and it was diuretic responsive, suggestive of portal hypertensive ascites, and patient underwent LVP once. Past history, patient had a significant history of jaundice 2 years back, which was treated by the local physician. She did not have any addictions, no chronic medical illnesses, and no history of liver disease in the family. On physical examination at presentation, patient was having grade 2 encephalopathy. She was drowsy, she was ecteric, and she had epididyma. There was moderate ascites and hepatomegaly, liver span of 15 centimeter. There was no splenomegaly. And on baseline parameters, the bilirubin levels were 22 with raised AST and ALT with ratio more than 2, and INR was 2.1. So all the viral markers were done, which were negative. ANA was being found positive around 3+ with titer of 1:100. IgG was also significantly elevated with more than 1.1 times. Sepsis workup was also done, which was found to be negative. Procalcitonin was done as a routine, was also normal, and GMI was also normal. On imaging, ultrasonography was suggestive of cirrhotic liver with the normal spleen size with mild ascites. The upper GI endoscopy screening was suggestive of no varices, no gastric varices, and no esophageal varices. So, being suspected of autoimmune hepatitis, the patient was subjected to liver biopsy, which was done by transjugular route. HPG was measured during the procedure. It was 14, suggestive of the portal hypertension. And the biopsy was suggestive of interface hepatitis with chronic mononuclear infiltrates, including the plasma cells, pseudo-rosetting, imperipolysis, and bridging fibrosis, nodal formation, and cirrhosis. So the final diagnosis we made after evaluation was ACLF. This patient is fitting in both the definition of APASL and canonic. Acute component being AIH flare, chronic being the cirrhosis, which is autoimmune related, and ascites, which is currently controlled, and she had a grade 2 encephalopathy. CTB score of 12, MELD of 26, with MELD sodium of 30 and ARC score of 9. So coming to the next case, patient 49-year-old male presented with the jaundice and ascites. This is a similar presentation to the previous case. The onset of jaundice and ascites is within 28 days. And the jaundice was again painless progressive, preceded by the loss of appetite and fatigability. So this jaundice is preceded by the prodromal symptoms, and it is worsened by the history of complementary medicines. Ascites was progressive, uniform, and diuretic responsive. Patient did not have any addictions, although patient had a significant history of psoriasis, and he had a history of initiation of methotrexate recently 1 month before the onset of the symptoms. On examination, patient was ecteric, hepatomegaly, which was firm, and liver span of 17 centimeter with moderate ascites and no splenomegaly. On baseline evaluation, patient had a bilirubin of 25 with INR of 1.7. Viral markers were done because patient had a prodromal symptoms. HBsAg was positive. IgM anti-HBC also came positive. With DNA was very high of log 7. HBsAg was also positive. And on presentation, patient also had sepsis screening was also done. Procalcitonin was raised, and patient also had a history of fever at admission. Ultrasonography was suggestive of the cirrhotic liver with moderate ascites. There were no esophageal or gastric varices. So this patient is also fitting in both the definitions, APASL as well as canonic criteria. Acute component being HBV reactivation plus superadded drug-induced liver injury, with chronic component being HBV cirrhosis and decompensation in the form of ascites. His MELD score was 24 with MELD sodium of 26. CTP is 12 and ARC score of 7 with the comorbidity of psoriasis. So coming to the management of each case one by one. The first case, which was presented by Dr. Surinder, I will be discussing his management. This patient was ACLF and the acute component was severe alcoholic hepatitis. So severe alcoholic hepatitis with the DF score of 95 comes into the severe category along with the MELD more than 20. In this case, it is 28. So it is also suggestive of severe alcoholic hepatitis. So prognostic models for severe alcoholic hepatitis, we grade the severity as discussed earlier is MDF score and the MELD score. Lille score is used when we use steroids. So the primary management of the severe alcoholic hepatitis is steroids only. So we will be discussing the algorithm. At the admission for severe alcoholic hepatitis, we screen all patients for infections. And in the absence of infection only, we can try prednisolone in the absence of other contraindications. So the usual dose is 40 mg per day. And we assess the response of steroids at day 7. If the response is positive, defined by the Lille score of less than 0.45, we continue steroids further. Or if the Lille score is more than 0.45, suggestive of non-response to the steroids, we discontinue the steroids. Or if at the baseline patient had infections, we start antibiotics and other supportive measures. And if the infection is controlled, we can consider him for the steroids. Otherwise, supportive measures need to be continued and other alternative therapies to be considered. So most important part is the contraindication to the steroids in alcoholic hepatitis. The untreated infections, of course, are the most important contraindications. Uncontrolled GI bleed, renal failure, acute pancreatitis, uncontrolled type 2 diabetes, and psychosis are the most important contraindications for the steroid use. So in our patients, we have actually started steroids on day 7. At the start of the steroid, patient had a bilirubin of 35. And after day 7, the patient was, as per the Lille score, patient was responder, and we continued steroid for 28 days. And we can see the prognostic markers improved significantly from the baseline, from MELD score 28 to 19, MDF score from 95 to 39, and ARC score also came down from 9 to 6. So this is the trend of the MDF score, which was 95 at the initiation of the steroids. It came down to 39. And the bilirubin, which was 35 at the time of initiation of the steroids, came down to 7.5. MELD score, which was 28 at the time of initiation of steroid, came down to 19. So this patient survived, and patient is on our OPD follow-up. So another important population in the alcoholic hepatitis group is steroid ineligible groups and the steroid non-responder group. Around 70% of the severe alcoholic hepatitis patients are ineligible to the steroids. And all those patients who are tried on steroids, around 25% are non-responders. So whole population of the severe alcoholic hepatitis, 80% are not amenable for the treatment to the steroids, and we need to consider some alternative therapies. So most important alternative therapy we, of course, consider in all patients is liver transplantation, but it is not feasible in most of the patients. So we have some upcoming therapies which are being used and are promising. It is first is fecal microbiota transplantation, liver regeneration therapy, the form of GCSF therapy, and the plasma exchange. Coming to the second case management, which was autoimmune AIH flare with the MELD score of 26 and grade 2 encephalopathy at the presentation. So we will be discussing the algorithmic management of the AIH ACLF. All the patients of AIH ACLF should be screened for the organ failures and sepsis at the baseline. If the organ failures are present or sepsis is present, we need to control the sepsis, and we can, if the organ failures are less than 2 and sepsis is controlled, we can consider the patient for liver transplantation, or in the meantime, we can consider the patient for plasma exchange and CRRT. If the organ failures are more than 2, that is extra hepatic organ failures are more than 2 and uncontrolled sepsis is there, we need to consider only for the supportive care. And if these organ failures or sepsis get improved, we can again then consider the patient for the liver transplantation and alternative therapies. Suppose if the patient is not having any extra hepatic organ failure or patient is not having any sepsis, then we can only consider for the steroids if the MELD score is less than 27 as per the available literature. The steroid response is good only in the patients who have MELD score less than 27. And at the 2 weeks of the steroid therapy, we should be reassessing our patients for the response. And if there is no response to the steroids, we need to consider early liver transplantation in such patients. So in our patients at the day 8 of the admission, we started him on her on the steroids. Bilirubin at the start of the steroid therapy was 22, which came down to 2.9 at the day 22. And the liver enzymes, AST and ALT were also coming down with the therapy. This is the trend of the AST and ALT along with, bilirubin and the MELD scores. The steroid was started at day 8. The bilirubin came down significantly at day 28, and the MELD score also comes down. So coming to the prevalence and outcomes of the AIH ACLF, AIH flare as a cause of ACLF is only, there are limited literature available, although the literature suggests the 2.8% prevalence among the ACLF patients. And the high dose prednisolone is effective in 20% to 100% of the patients with severe AIH. Patients with less severe disease with the MELD score of less than 27 have favorable response. And the higher prevalence of hepatic encephalopathy and the F3 fibrosis suggests the negative response to the steroids. So when to consider these patients for the early liver transplantation? The first is the steroid non-response, the biochemical non-response, which is defined by the lack of reduction of transaminases of more than 25% after 2 weeks. Clinical non-response is defined by non-improvement in the MELD score or bilirubin and INR at 2 weeks. MELD score more than 27 at presentation should be considered for early liver transplantation, and encephalopathy grade more than 3 should also be considered for the liver transplantation. Coming to the management of third case, which was ACLF HBV reactivation plus superadded drug-induced liver injury with MELD of 24. So in this population, HBV reactivation, most important is to know the risk factors for the reactivation. The host factors are old age, male, cirrhotics, diabetics, and the SCC. Viral factors which are prone for reactivation are high HBV DNA, HBAG positivity, low anti-HBs titers. Immunosuppression, the high risk of reactivation in the B cell depleting agents, high dose of corticosteroids for more than 4 weeks, anthracyclines, stem cell transplantation. Moderate risk is in systemic chemotherapy, tyrosine kinase and proteasome inhibitors, and low risk in steroid less than 1 week and methotrexate. In our patient, the methotrexate was suspected as a culprit. So in this population, prevention is better than the treatment. Antiviral prophylaxis is recommended for patient at high risk, more than 10% risk of reactivation, and should be considered and can also be considered in the moderate risk of 1 to 10% of HBV reactivation. With the patient at low risk, that is risk of less than 1%, the patient should be monitored closely every 1 to 3 months. Antivirals should be started at least a week before immunosuppression and need to be continued for 12 months post discontinuation. So at the baseline, every HBV ACLF patient should be screened again for the organ failures and sepsis. The patients who have no organ failures can be continued for the medical management with antivirals and other supportive measures. Those who have grade 1 ACLF, that is 1 organ failure only, they should be evaluated at day 3 and day 7 for further progression of organ failures. And if they develop more organ failures, then they should be assessed for the liver transplantation. Those who present with the grade 3 ACLF, that is 3 or more organ failures, should be assessed for the LT at admission only. So in our patient, the patient had a bilirubin of 25 at the admission and grade 2 encephalopathy along with the history of fever and also drug-induced liver injury. So we continued on the antivirals, started antibiotics along with the other supportive measures, and the bilirubin spontaneously came down from 25 to 11. Enzymes were also settling down. This shows the trend of the MELD and bilirubin, which was coming down with the therapy. So when to consider early liver transplantation in this subset of the ACLF, the MELD more than 23 at presentation in HBV ACLF is a consideration for the liver transplantation. ACLF grade 3, that is 3 or more organ failures at the admission. ACLF grade 2, that is 2 organ failures at day 3 and day 7 of admission, should be considered for early liver transplantation. So next, I will be discussing our data on ACLF. We had 82 patients of ACLF. The mean age of our ACLF group was lower, was 41.8 as compared to the European population, which is older, and the ARC data is comparable. Bilirubin and INR was higher in our population, with bilirubin being 18.6 and INR of 2.9, which is higher than the other groups. And this is probably because we are dealing with the more sicker patients. MELD score is higher. It is mean score of 29.5 in our data and as compared to the 27 in the ARC. So the most important acute precipitant was alcoholic hepatitis in 39% of the patient, and second most important precipitant was sepsis, that is 24%. And the third important cause in the COVID pandemic was, of course, the drug-induced liver injury, being 15% of the cases. Comparing with the other groups, the acute component, alcoholic hepatitis, were more significantly higher in our group, and the sepsis being most important in the canonic group. The autoimmune flare and viral hepatitis are other important causes of the acute flare. In chronic liver disease, the alcoholic liver disease was the most important culprit, and the second most important cause was the NASH, that is non-alcoholic steatohepatitis. Third most important part is the HBV-related cirrhosis. Comparing to the other groups, we had more number of chronic hepatitis B and C patients as compared to the canonic and ARC group, and the canonic group had more alcoholic liver disease group, that is, and ARC is also having the slightly higher percentage of the patient with alcoholic liver disease. So distribution of organ failures and the distribution of ACLF according to the definitions. In our patients, 67% patients were fitting into the canonic ACLF alone, and 26% of the patients had apasal as well as canonic. They are fitting into both the definitions of the ACLF, and 7% of the patients were fitting only in the apasal ACLF. Coming to the organ failures, the 35% of the patients had 2 organ failure at admission, and 17% of the patients had the 4 organ failures at the admission. 16% patients had the 3 organ failures at the admission. So most important organ failure is, of course, the hepatic failure, which is present in 72%. So the important part is 28% of the patients of ACLF do not have any hepatic failure because they are fitting into the canonic definitions. Second most common organ failure being the renal and the coagulation. The least common organ failures were respiratory. Survival was assessed at day 28. It was 65.9%. 54 patients out of 82 survived at day 28. The mortality increased as increase in the grade of ACLF, being 10.7 in grade 1 with one organ failure, 17.2 in grade 2 with 2 organ failures, and it was very high in patients who present with 3 or more organ failures, being 51% in grade 3. So we also assessed the mortality survival in the ALD ACLF group, which is slightly higher than the whole population. The survival was only 48.2% as compared to 65.9% in all ACLFs. Coming to the data of AIH ACLF, the prevalence of apasal AIH ACLF in our data was 3.6%, and the survival in apasal ACLF was 100%, and all the patients were eligible for the steroids. Canonic AIH ACLF had a survival of 50% only. The survival of AIH ACLF was comparable to the whole population, and it was 66.6% as compared to 65.9% in all ACLF. So summarizing our data, the apasal and canonic definitions are the most accepted to identify ACLF, with baseline severity being assessed by ARC score and the CLIFS ACLF as applicable. ACLF is a dynamic syndrome, and prognosis needs to be assessed frequently, especially at day 3 and day 7 of admission, as we need to refer the patient for the liver transplantation. Alcohol-related ACLF is more common and has a high 28-day mortality. Liver transplantation should be considered early in patients with 2 or more extrahepatic organ failures at admission. Specific therapies can be used in patients without organ failure to prevent progression and improve transplant-free survival. ACLF, HBV, and ACLF AIH are potentially reversible conditions if identified early and treated with the specific therapy. So, before ending, I would like to give an algorithm for the management of the ACLF. All the patients of ACLF, we need to identify first the acute insult, second the chronic liver disease part, and third is the liver failure. Liver failure should be graded and severity needs to be assessed at admission. So if we need to remember one thing from this presentation, we need to remember that if the MELD score is more than 30, the patient is a candidate for liver transplantation. Any ACLF who has MELD more than 30 at the time of admission should be considered for the liver transplantation straight away without any confusion. So those patients who have MELD more than 30 without any organ failure can be considered for the liver transplantation straight away. Those who have 2 or more organ failures, they need organ support and bridging therapy, and their recovery needs to be assessed at day 4 and day 7 of the admission. If there is recovery, we can consider them for the liver transplantation. If the patient is not recovering, of course, we need to give best supportive care. All those patients who have MELD score of less than 30, they need to be reassessed at day 4 and day 7. If there is no further organ failure, patient can be continued on the specific therapies and regenerative and bridging therapies with the monitoring. If there is deterioration, then we can consider for the liver transplantation. Otherwise, if there is new onset of the organ failures, the early liver transplantation should be considered. So with this, I want to thank you all for your kind attention. And I would also like to invite you all to our upcoming conference on current perspectives in liver disease on 25th and 26th of February. Thank you.